So, oh, thank you. So got the recording. And so Dr. Brennan has extensive experience in palliative care, specifically for patients with kidney disease. And so the presentation that we'll hear from Frank, how long do you think that will go for, Frank?
Yeah, around about the 20. I've got targeted about the 20 minutes. It might go a little bit longer, but I'm very happy for you to perhaps just indicate, and I can cease, and then we can go straight on to questions or the rest of the presentations. Yeah.
Yeah, I think that 20 minutes sounds good. And so during the presentation, though, Frank, if people would like to raise questions, then they can do so perhaps best through the chat. And then if appropriate, we'll try to, or if possible, we'll try to hold off discussing those comments or questions until you've completed your presentation.
Sure. Thank you, Renal.
So, and then after that, we'll then head over to India, where we have two case presentations as well. So we should start now in the interest of utilising the full 90 minutes. So it looks like we've actually got a good number of attendees from both Australia and India, as well as I think even from Bhutan as well. So that's fantastic. So over to you, Dr. Frank.
Good, that's great. I'll just share my screen and hopefully this goes okay. We'll see how it goes. Okay, so first of all, can everyone hear me? And can you see the first slide? Okay, and I'll just see if the slide goes through. Does it start to move through? Or is it stuck on the first slide?
No, Dr. Frank, it is stuck with all the slides together.
Okay. So in that case, what we might do then, is it possible for you to, I'm happy to stop share and you can share, and then I can say next slide. Would that be the best?
Yes, that would be good.
Okay, good. Well, I'll stop sharing and then allow you to have that, the presentation on the screen. Thank you so much. Okay, look, thank you so much for this. And I really appreciate the opportunity to speak to you all. I'm very much a admirer of the work of Project Hammer here over many years. And I know Anil's work and Adet's and many other people's work through this, and the great collegiality there with our Indian colleagues. So today, okay, I'll speak up a little bit. Is that better? Okay, very good. So today's presentation is on symptom management in kidney failure. Next slide. Perhaps just to set a context, which is important, in the modern era, an alliance between the disciplines of nephrology and palliative care is emerging. Next slide. And this is now being called kidney supportive care. Next slide. The International Society of Nephrology has endorsed kidney supportive care as one of the essential aspects of integrated kidney care globally, along with dialysis and transplantation. This was a major and very significant document. So this is fascinating, isn't it? From within the discipline of nephrology, they have identified this area, this alliance of palliative care and nephrology, as equally important as all other aspects of renal medicine, including dialysis and transplantation. Next slide. Following a series of echo lectures organised by Dr. Nandini Valath, many of you will know her, and a masterclass in Manipal organised by Nandini and Dr. Naveen Salines down in Manipal, there was ultimately a very significant document published in the Indian Journal of Palliative Care in May last year entitled Renal Supportive Care in India. And I would recommend certainly those in India to go to that document. It's a multi-authored document with quite a few sections, and that would be a very good preliminary for you. Next slide. So let's talk to the topic then, symptom management in kidney failure. Next slide. So this is a particular patient I met some years ago that was so striking. She was in country New South Wales. She was a 53-year-old Indigenous woman who had type 2 diabetes, hypertension, diabetic nephropathy, and she'd been on hemodialysis for 5 years. Next slide. When I met her, she shuffled into the room. There was her head down. There was no eye contact. Next slide. So I started to talk to her. She was initially reluctant to talk, but eventually she started describing her symptoms. My legs moved through all the night. So she had severe restless leg syndrome, and I'll talk about that later in this talk. Next slide. I itch all the time. Often it becomes ferocious. Notice that word ferocious, how awful this was. So she had severe uremic pruritus for an extended period. Next slide. My feet and calves burn and get pins and needles. It is awful. She also then had severe diabetic peripheral neuropathy. Next slide. And sleep, I asked her. Next slide. I don't sleep. I doze in 5-minute lots. I sit in a chair and put my elbows on my knees to hold them still, and I pray to die. In palliative care, we regularly are seeing patients who are suffering, but this woman was the image of suffering. What possibly could we do for these terrible, terrible symptoms? Next slide. So the overview of this talk is looking at the issue of the basic facts and principles about symptom management, the evidence for it, the lessons from other disease settings, and also, if we have time, looking at how a kidney supportive care clinic can operate to try and help these symptoms. Next slide. So foundational facts. Next slide. First of all, symptoms in this cohort of patients are prevalent, they are multiple, and they are burdensome, just as we've indicated with that case. Patients with kidney failure, whether receiving dialysis or being managed conservatively, as in not on dialysis, are highly symptomatic. Next slide. What are the common symptoms experienced by patients with kidney failure? Next slide. We'll start with dialysis patients. Next slide. This was a major study done some years ago, but probably the largest study looking at symptoms of dialysis patients. Next slide. And as you can see, a large number of symptoms, but very high, high prevalence rates in many of those symptoms. I'll let you briefly look at that chart there. In many studies, the mean number of symptoms that a dialysis patient will experience will be 9, which is a considerable number. But look at just the sheer weight and extent of these symptoms. Next slide. What about those who are not on dialysis? What symptomatology may they experience? Next slide. So these are two particular studies looking at this particular issue of patients with not on dialysis and their symptomatology. Next slide. So as you can see, those studies just represent just the huge weight of the symptomatology again, as you can see, with fatigue and pruritus again ranking the top 2 in terms of symptomatology, but others really troubling the patient as well. Next slide. So studies do show that patients themselves rate symptoms and their management very highly, as you would imagine, because the patients are experiencing those symptoms. Next slide. Symptoms interact and compound with each other. Next slide. So I've given you the example with that case study of nocturnal symptoms having a major effect on sleep and potentially leading to significant daytime fatigue. Now, fatigue is very complicated, not simply these symptoms, but it is very interesting if you can come back to the source of those symptoms, the uremic pruritus, restless legs or pain, and deal with those. You may well be able to give the patient a significant sleep dividend, improve their sleep. Next slide. Symptoms may derive from the comorbidities, and one of the big issues around the world is the rise of diabetic nephropathy. So this is becoming such a huge issue in terms of the diabetes, the macro and microvascular complications, including nephropathy, but lots of other issues that can come with the diabetes. And also in the older age group, of course, musculoskeletal disease, etc., etc. Next slide. Kidney failure constrains the use of medications. We need to be careful with how we use our medications. Next slide. Pharmacology in the context of kidney failure and dialysis can be complex. Next slide. There are gaps in knowledge. Next slide. Recommendations sometimes conflict, which does make it difficult. Next slide. What symptom instruments can you use? Next slide. So one that's been used if not universally, then a lot through the world, is the so-called APLI Renal. And next slide. So this is a validated symptom inventory tool for renal patients. Now, originally, some of these symptom inventory tools were cancer symptoms, but didn't include particular renal symptoms, such as restless legs and uremic pruritus. So as you can see on the left side of the screen, there are 15 physical symptoms. On the right side of the screen does include anxiety and depression, but also psychosocial and spiritual issues. Do you feel at peace? Do you feel you're able to speak to your family? So this is, as I said, validated and very, very useful for us. And patients routinely will fill this symptom inventory out in the waiting room before they come in to see us. Next slide. What is the evidence for symptom management of kidney failure? Next slide. With notable exceptions, there is no or little evidence on symptom management, specifically in the context of dialysis or conservative. Next slide. In terms of the level of evidence, the symptoms fall into several categories. Next slide. Okay, symptoms with a solid and expanding body of evidence in CKD. The outstanding symptom there is uremic pruritus, and I'll turn to that very soon. Next slide. Symptoms with a syndrome with authoritative international evidence-based guidelines. Restless leg syndrome. There's an international restless leg syndrome study group, and they put out intercurrent international guidelines. Next slide. Then there are symptoms with a small body of evidence, such as depression or taste changes. Next slide. And then there's many, many symptoms where we actually don't have evidence in CKD, but management is based on general principles and extrapolation from the general population. Be careful, of course, in terms of the use of the medicines. And they include, next slide, things like pain, nausea, vomiting, shortness of breath, constipation, insomnia. So really a dearth of evidence here. Next slide. As kidney supportive care matures, symptom management is a field wide open for research. Next slide. The principles of symptom management. Next slide. Well, first of all, think of the cause. If this person's describing pain or nausea or itch, think, okay, what's causing this? Is it to do with the kidney disease, or is it separate to the kidney disease? Next slide. And being meticulous is very important in palliative care, isn't it? So that you can see the sea of symptoms here. So you just need to be meticulous. You don't miss symptoms, or a patient is not being stoical and not talking about symptoms, because that certainly can occur. So being meticulous, using these validated tools certainly helps us. Next slide. The principle of non-abandonment, which is very, very important in palliative care, is sitting with the patient and listening carefully to the patient, listening and empathizing with their suffering. And also, if you are struggling with symptomatology, investigating, thinking, talking to colleagues, reading the literature, potentially referring on to others, but always at the end of the day, sitting and listening to the patients, because that's what they want. The fact that you are involved with and understand and are thinking about what they're going through. Next slide. The role of a multidisciplinary team is extremely important, and I work very closely with renal supportive care nurses and other people as well, other allied health in terms of dietitian, social work. Next slide. So the principles of symptom management are those ones we've just spoken about, and I think that that's very, very important as you sit down with these patients. Next slide. Time does not permit a full review of all symptoms, so I'm going to present some representative symptoms and outline a general approach. Next slide. So the representative ones are uremic pruritus, restless legs, and pain. Next slide. Uremic pruritus. Next slide. Over the past few decades, there's been a quite revolution unfolding in the understanding of the basic pathophysiology of pruritus, before we even get to uremic pruritus. So there's a lot of change that's occurred that the audience may not be aware of. Next slide. In the skin, there are nociceptive sensory nerves that transmit various sensations, and one of those sensations is pruritus. Next slide. Look at this remarkable photo. It was published only a year or so ago from a team in Italy. So the red is the nociceptive, the nerve endings, the sensory nerves going into the top layer, of course, is the epidermis, the bottom layer is the dermis. So those sensory nerves going into that, and look how fine, detailed, and finally nuanced this whole story is with the fibers branching off. The red is the fibers, the blue are the skin nuclei. It's a remarkable photo. And it's a remarkably beautiful photo too, isn't it? Next slide. So C fibres are the main, C and A delta fibres, but C fibres I'm going to concentrate in terms of itch. Next slide. So 5 to 10% of C fibres are dedicated to itch. Next slide. For many years, the assumption was it was all to do with histamine. Next slide. Until these studies came along, which changed everything completely, that of those itch fibres, only 10% are histamine dependent and 90% are histamine independent. So this whole other histamine independent itch story out there. And uremic pruritus is almost certainly histamine independent. So the myth, one of the myths is that all itch is histamine mediated. Next slide. And that the second myth is the best line medication for itches, whatever cause, are antihistamines. Next slide. Let's talk about the pathogenesis of uremic pruritus. Next slide. Look, it remains obscure. We actually don't know the mechanism. There's lots of theories, but we actually don't have a clear answer. Next slide. But we do know, and this is fascinating, isn't it, that the itch fibres that transmit the itch signal with uremic pruritus follow a non-histaminergic pathway to the brain. Next slide. So we're enormously indebted to this particular publication from 2020, a Cochrane review on the management of uremic pruritus. Next slide. And they said, and I'll quote, of all treatments for uremic pruritus, gabapentinoids were the most studied and show the greatest reduction in itch scores. Next slide. There's this another class of medicines called the kappa opioid agonists, which are getting a lot of attention in this area. They may also reduce itch, but indirect comparisons suggest a much more modest effect in comparison to the gabapentinoids. These are not available in either of our countries, these medicines, but they will come available at some point. So we guess we do need to understand and know about them. Next slide. Interestingly also, and some of these medicines I haven't even used, but they talked about the moderate evidence, if you like, for some of these turmeric, which is fascinating, coumaron, zinc sulfate. I've never used zinc sulfate, oral montelukast, which is a leukotriene B4 antagonist, and tropical capsaicin. I'm sure you've heard of that. It's out of the chili family and usually not tolerated on its own. All of those showed an itch score reduction. However, those reductions were modest, really. Next slide. So that got me very interested to work out why these medicines might work. And turmeric does have an inhibitory effect on TNF-alpha interleukin 6, and the others do have some rationale behind them. Next slide. So what's our approach in a kidney supportive care? Next slide. First of all, we ask every patient, every clinic, whether they experienced itch in the past week. Next slide. We do a good history and examination. Here it's important to exclude other things because not every patient with kidney disease with itch has uremic pruritus. And several times we've been caught in the clinic where everyone's assumed it's uremic pruritus and it was scabies or atopic eczema or psoriasis. So we just need to be quite careful, a bit of a good physical examination and history taking. Next slide. Step 3, what are the therapies? Well, we've gone back to, this is the Cochrane story, but what do we do in the clinic? Next slide. So there are topical preparations, oral medications, and ultraviolet B. Next slide. The first thing, topical, next slide, is moisturizers. This can be extremely important. Next slide. So xerosis or dry skin is common. It doesn't cause uremic pruritus, but it certainly exacerbates it. So we recommend Sorbolene or QV cream. Next slide. Also, we advise patients to use plain non-perfume soap. Goat's milk soap is recommended, or body cleansers. Next slide. Capsaicin cream, yes, evidence there, but look, it does cause this transient burning and people don't tolerate it. Next slide. Next slide. But what we're doing is mixing the capsaicin with the heat of the capsaicin with the cold of menthol. And menthol acts on cold receptors that have an anti-itch effect. So both of them have the anti-itch effect, but both, if you get the balance right, you're going to balance that out. Next slide. And we've also now been recently adding in lignocaine, working on the sodium channels of the itch fibers. So that combination can be quite effective. If necessary, it's not usually that we reach to those. Next slide. Systemic therapies, next slide. So the gabapentinoids, as you saw from the Cochrane review, highly regarded. Next slide. But the dosing regime must be very careful. Next slide. On dialysis, gabapentin 100 milligrams after each dialysis. So that may be 3 times per week if they're on hemodialysis, compared to someone with normal renal function where you might be moving to 3 times per day. Titrate to effect. Next slide. If they're conservative, eGFR under 15, then 100 milligrams Nocte. If the eGFR is very low, say below 5, I'd probably do it every second night. Next slide. Ultraviolet B therapy, good evidence for that, yes, but you need a dermatologist and a machine there. What's our experience over 11, more than 11 years now? Next slide. So we did many patients, as you saw, with the IPOS. Next slide. And our prevalence rates are consistent with the international data. Next slide. And okay, what about those who had severe to overwhelming itch? What happened by their 3rd clinic? How do we go in terms of treatment? Next slide. Well, as you can see, a good result really, that this with assiduous, careful, conscientious symptom management, you can start to make a difference. So this is perhaps a slide just to indicate we're beyond the era of nihilism where everyone is like, we're not sure what to do, or put everyone on antihistamines or corticosteroids. No, we can be much more nuanced and careful, following the literature, and hopefully much more successfully. Next slide. But are we able to sustain that result over time? Next slide. Yes, I think obviously there are ups and downs, but coming from that severe to overwhelming over a significant period of time, obviously less patients as time goes on. So that's the renal replacement patients. Next slide. And that's the conservative group again, where you can start to hold that mostly, though things can surge at certain times. Next slide. Restless leg syndrome. What is that? Next, that's it. Yeah, it's an urge to move the limbs with a feeling. Often people struggle expressing their feelings. An urge and the motor restlessness, so the legs start to shuffle and move. Symptoms exclusively while at rest or lying down, and much better when they move around. Symptoms are worse at night, and there cannot be another thing. Now, just imagine this. This is the story where people, like our patient, the patient I described, is up all night walking around because they virtually cannot lie still because of the restless legs. So it's a very, very awful thing and a traumatic effect on sleep. Imagine if you're a dialysis patient on a dialysis chair with restless leg syndrome, because people are wanting to get up off the chair, feeling that urge, and the nurses are saying, no, you need to continue the dialysis regime. So it's been associated with repeated aborted dialysis sessions. Next slide. So not all kidney patients who have have changes in their legs have restless leg syndrome. Next slide. So there can be lots of, next slide, it can be lots of different, next slide. Yeah, those cramps or arthritis, people might use the word restless, but a careful history to see whether it's truly restless leg syndrome. So I pause and ask them, tell me what you're feeling. And usually the ones who have it give the textbook definition. Next slide. Associations, next slide. Sleep disturbance and daytime somnolence, as you would expect. Next slide. Premature cessation of dialysis sessions, as stated. Next slide. Reduced quality of life, hypertension, new cardiovascular events, and mortality indeed. Next slide. Mechanism, next slide. So this is to do with the production of dopamine. This is in the basal ganglia. So basically the production of dopamine. Now, you may or may not realize, but iron is really important in this whole process. Iron is a cofactor in so many processes, and iron sits in the dopamine 2 receptors on the other side. So the next slide. So the theory is that there's a problem with iron transport into these cells. So this is not systemic iron. You may have pristine iron levels, but it's trouble with the transport of iron into these cells. And why is this so circadian? Why is it so worse at night? Well, this entire process is circadian. Our iron metabolism is circadian, and this area of the brain is intimately connected to the hypothalamus and the circadian clock, if you like. Next slide. So, but it's more than simply dopamine. There's lots of other things that are now starting to come out, other peptides and products that may be included in this process as well. Next slide. So, management. Well, it would be fantastic to give a dopamine agonist at night. And sure enough, next slide, there's good evidence for it, but we use the first of these classes, the one that's in bold. So pamprexol, ropinirole, rotigidine. We don't use the second class because they can cause significant other side effects. So, but it's that first group that we use. Next slide. You can, in this first group, get augmentation where you can get a shifting in the timing of the onset of restless legs, and rebound where the person's fine overnight, but then they wake up with restless legs. So that's a whole story in itself. Next slide. Gabapentinoids, our friends, return. So 2 RCTs have shown efficacy for gabapentin in the treatment here. Next slide. 3 have shown very good evidence for pregabalin, comparing pregabalin with pramipexole and placebo. Next slide. So 2 found that pregabalin was significantly more efficacious than pramipexole, and 1 found pregabalin improved treatment over placebo, but not pramipexole. But pregabalin didn't have augmentation. Next slide. Opioids. Now, this is very interesting, where opioids come into play. I guess the theory is that the opioids have a protective effect on the dopamine cells that have been subject to iron deficit. So this is fascinating because this may well help. Next slide. And sure enough, this particular paper, written by leading international experts, did show significant efficacy of oxycodone and naloxone in the context of restless legs. So this is a very interesting development. Next slide. Also, there's some evidence of the use of methadone. Methadone is an interesting medicine in kidney failure because it's not dialyzed and it's mainly fecally excreted. Next slide. Iron infusions, next slide. Yes, they do work, but the effect fades after 4 weeks, and we're not repeatedly giving iron infusions to patients. Next slide. Intradialytic exercises. This is interesting. This Italian group that put pedals at the base of the dialysis chair so the person can move their legs and feel and do the good evidence for the use of those during dialysis. Next slide. So what do the international guidelines say? Next slide. So they come out with the gabapentinoids may be considered for initial treatment. So as first line, these drugs are effective and at little risk of augmentation. This story of shifting of the timing. Next slide. If dopamine drugs are elected as initial treatment, the daily lows should be as low as possible. Next slide. Other medications to consider, so the oxycodone and methadone. Next slide. Okay, so that's very interesting, isn't it? So we've got gabapentinoids leading the way with the Cochrane review in uremic pruritus and also first line for restless legs as well. Pain. Okay, next slide. This is such a large subject and a topic, and I cannot pretend to give you an overarching story here, but just perhaps some key points. Just be aware of the multiple causes of pain in this group. They may be related to the kidney failure, its treatment, or the comorbidities. Next slide. So the pain related to the disease may be polycystic kidney disease, big cysts in the kidney pushing up onto the viscera and indeed down onto the lumbar vertebra and setting off pain. Renal bone disease, amyloid, including carpal tunnel syndrome, and calciphylaxis. I'm not sure if any of you have seen this, but it's a feared and rare complication of kidney disease where you get necrosis in the skin, which is disproportionately painful to the size of that and associated with high mortality. Next slide. Then you get pain secondary to treatment, like peritoneal dialysis with recurrent abdominal pain, where you might have a fistula in your arm leading on to hemodialysis, but there's not quite enough blood heading into the fingers. You might get the Steele syndrome, and also cramps, intradialytic headaches. Next slide. So, but then, of course, you've got a large number of comorbidities where people may have osteoarthritis, diabetic peripheral neuropathy, etc., and indeed cancer pain. Next slide. So I think there's a pain etiquette, as we know, inquiring regularly of our patients, responding compassionately, treating competently, and if we're not sure what to do, referring on wisely. Next slide. Okay, so we probably should summarize this strategic approach to pain management. Next slide. Okay, there's very, very little evidence in pain management in CKD. Next slide. There is, however, a growing understanding of the basic pathophysiology of pain. Next slide. And we do know, of course, that very classic differentiation, if you like, of nociceptive and neuropathic pain. Next slide. So there is an increasing, although not complete, understanding of the pharmacology of these medicines. Next slide. So this paper I would highly recommend. This is Sarah Davidson. I'll introduce you to her. She's a nephrologist from Canada. She is a leading light in kidney supportive care and is probably the international expert on CKD and pain management. she's written a series of articles. So if you were to get one article by her, this would be the article to get, because she goes through things beautifully and explains things very well, and perhaps puts aside a lot of practice that was sort of getting a little bit out of hand, if you like. Next slide. So she started to talk about the stepwise approach. Next slide. So she, in a very orthodox way, said, ladies and gentlemen, particularly my colleagues, nephrologists, we need to separate this pain. Not all pain's the same. There is this thing called neuropathic, nociceptive and neuropathic pain. And what she was saying to them was, don't start everyone on opioids, because opioids may not be the right thing to do. And particularly with neuropathic pain, start to think of other agents. And if it's nociceptive, look at non-pharmacological agents, medicines or treatments, say for osteoarthritis, etc. So to a palliative care audience, we'd look at this and say, yes, this looks quite reasonable. But to a nephrology audience who are particularly sort of driven to deal with pain by starting everyone on opioids, it's a halt. It's saying, no, be very careful. Be careful is what we're doing, and be conscientious here in terms of the evidence, next, or the lack of evidence in CKD, but the evidence that we know from the general population. So what's an example of this approach? Next slide. So what about the dialysis patient who's got the terrible diabetic peripheral neuropathy? Next slide. So currently there are absolutely no evidence-based consensus guidelines on this management for CKD. Next slide. And look at this remarkable quote. Virtually non-existent. Now that was written back in 2010. Little has changed since. So there hasn't been a body of evidence in this area in CKD. Next slide. So we know the pain is neuropathic. There's a significant body of literature on the management of painful diabetic peripheral neuropathy for the general population, and that literature includes several international evidence-based guidelines. Next slide. So we go back to Sarah's paper. This is neuropathic pain. Let's see what we can do, and be careful with dosing and follow that through. And I think that that's quite reasonable. So it's really using those international, the whole population guidelines, and then filtering it through the known pharmacokinetics of CKD. Next slide. So what about Our Lady? This poor woman who actually, I was reported, she was told to me that she was near suicidal with her symptoms, so I could see why. Okay, what could we do? So what I did is I spoke to her and I said, I think I can help you. She said, no, I don't think you can help me. Nothing can help me. I'm going to start you on one medicine. She said, doctor, that doesn't make any sense. I've been telling you about all these things and you're talking about one. I said, yes, one medicine. I'm going to start it gently, and we may need to lift it up. It may or may not work. These are the side effects. But why don't we start you on this medicine called gabapentin, knowing its efficacy for uremic pruritus, restless leg syndrome, and diabetic peripheral neuropathy. So 9 days later, I rang, it was in a rural setting, I rang that rural setting to see what was happening. Next slide. So we started at 200. Now, why did I start 200 rather than 100? Because she was so much younger than our patients, most of my patients, and also because her symptoms were so egregious, so difficult. Next slide. So they reported a complete ceasing of her symptoms and a markedly improved sleep, sleeping the best I have for a long time. Now, so this is a very interesting moment of professional reflection, because had I met that woman several years before, I would not have had the skill to deal with all these symptoms. But having met many, many kidney patients and being more and more confident about the use of these medicines, I was confident in the use of this medicine across several symptoms. Next slide. Next slide. Okay, what about the multifactorial symptoms? Next slide. So these are symptoms where constitutional symptoms, multifactorial, and they may not have a specific management. Next slide. So this could be insomnia, fatigue, anorexia. Next slide. So we talked about insomnia, certainly with that case, but that may be the product of multiple other symptoms. Next slide. All of these symptoms potentially could be driving insomnia. Next slide. Interestingly, the evening surge of melatonin that controls the circadian is absent in dialysis patients. So that's a whole story, and we're using more and more melatonin for these patients now. Next slide. Anorexia is a good example as well, but that could be lots of different reasons for the anorexia. Next slide. An approach to these multifactorial symptoms. Next slide. First of all, resisting the temptation to dismiss the symptom as to be expected or too difficult to understand and therefore beyond therapeutic intervention. No, we can work on this. We can try and think through this. Next slide. Take a thorough history, searching upstream for a cause. If the person is sleepy during the day, what's happening at night? And if it's a story that's, say, anorexia, is it to do with poor taste or nausea? Other things like early satiety. Next slide. Examples, next slide. So all of those could be factoring in to this story for those patients. Next slide. Now, look, Anil, I'm just conscious of time. If I'm over the 20 minutes, I'm happy to stop here. I've just got a few more slides, but I'm very happy to cease because it might be good to get everyone's engagement and the other two presentations, of course.
Yes, Frank, thank you for that, because unfortunately we're about just a little bit past 30 minutes.
Excuse me.
Sorry, no, that's okay, because I think it's been a treat for all of us to hear from your encyclopedic knowledge on this topic. So before we continue on, or if we do continue on, I would like to see, though, if any of the attendees have questions, because I think that what you have shown us is that some of our maybe preconceived notions on how to manage these symptoms may actually be incorrect. And I think a very good example is your comment to begin with about histamine or antihistamines, correct? So thanks for pointing that out. So I would like to just open it up either for comments through the chat, or if anyone would like to actually speak and let us know. We have one question, though, from Tara, a question as to whether we would be able to share the slides after this presentation. And so if that would be possible, Frank, that would be wonderful. And so the APLI and India team can distribute that.
Yes, and it's in their hands now. So I'm very happy for that to be distributed, Tara.
Thank you.
I have a question, Frank. My name's Sarah. I'm a nurse from Melbourne, Australia, and I'm sorry if it's a very obvious question, but I was just wondering, what's the rationale behind giving the patients the gabapentin immediately post dialysis? And I'm sorry if that's really obvious, but it just to me,
Sarah, no, it's a very good question, and actually we did struggle somewhat with that story. So the initial thought was we knew that gabapentin was going to be mostly dialyzed out. So we thought, okay, well, why don't we capture them right at the minute they're finished, just as they're finishing dialysis, to give them that medicine there, because we didn't want it to be in any way dialyzed out. However, we have noticed several patients saying, okay, gabapentin after, that helps my itch or my restless legs. But what happens is during dialysis, these symptoms surge back at me. And so what's happening, of course, is the gabapentin is being dialyzed out through that. So what we do for those patients, we give a pre-dialysis and a post-dialysis dose.
Okay, that's a very interesting answer. Thank you very much.
Frank, thank you. There is a question in the chat. What does augmentation mean in restless leg syndrome management?
Yes, thank you. Thank you, Anil. Look, I went through that very quickly. So augmentation is defined as, in restless legs, is if you give a medicine and the timing of the restless legs, which normally would sort of come on at 9 or 10 o'clock at night, particularly when the person's lying down, is suddenly starting to shift in the early part of the evening or even the late afternoon. So it's a disturbance to this circadian story, and it can be very difficult. And augmentation is a story for those dopamine agonists. And the restless leg study group talked about like rotating them from one, those medicines to another, or stopping them altogether and starting a gabapentinoid, or various other ways here.
Thank you. I think so. We're probably now needing to move across to India for the case presentations. So, Dr. Sridevi, can I hand over to you, please?
Sure. Thank you, Anil, for facilitating. Thank you, Dr. Frank, for the wonderful. There are so many things which we all learned, especially the itch, the pathway, and not antihistamines, the drug of choice for treatment. That's one important learning that we all had. Thank you so much. So we have two groups from India. So we'll start with the team from Vizag, Dr. Vidya and her team from Homi Baba Cancer Center and Cancer Hospital and Research Center. Dr. Vidya.
Good afternoon. Thank you so much, Dr. Frank. And I was just looking forward to see your slides going from taste. So I hope we have the slides, and we just hope we'll be able to see that too. So our team to present, we are in 2 rooms. I'm in the OPD. They have their presentation ready and they will start. So this is a patient, as we are a cancer hospital, our patient has carcinoma cervix. And this is something we see all the time, obstructive uropathy, very, very common in India. And so that's one of the patients that we have taken for our discussion today. It will be presented by our radiation oncologist and our palliative care physician. Thank you so much. Dr. Saujanya, can you please start?
Yes, ma'am. Good morning, everyone. Thank you, ma'am. Thank you, Vidya, ma'am. So I'm a radiation oncologist. I'm doing my residency present in Homi Baba Cancer Hospital. So as we all know, cervical cancer is one of the most common among females in our country. So I'll go through one of our case we have faced in our institution. So she's a 49-year-old female, premenopausal. She presented with complaints of white discharge per vaginum, and she also had a complaining of intermenstrual bleeding for over 7 months duration, which is also associated with complaining of lower abdominal pain.
Doctor, can I interfere? Your slides are not moving. We can just see the first slide only.
Can you see now?
No.
You can put it on a slideshow if possible.
Yeah, it's in slideshow only.
Slides are not moving. No.
We can do it from our end if you...
Now it's moving.
Yeah, now it is fine.
Okay. Okay.
Is this okay? Is this view okay for everyone?
Yes. Yes.
Okay.
Continue.
Okay. Thank you. So she presented with complaints of white discharging PV and intermenstrual bleeding, which is also associated with lower abdominal pain. At presentation, her performance status according to the ECOG was 1. So she was normal except with the complaints. And on clinical examination, locally, the disease was localized, and we staged as clinically stage 2B. So we have worked up. Our routine labs were within normal limits, except for anemia because she had a bleeding. And her creatinine at presentation was 0.7 milligram per deciliter, which was normal. Her biopsy came to be a moderately differentiated squamous cell carcinoma. And CT scan, which she has done outside, came to be a localized disease with the regional lymph nodes. So we staged as 3C2 post workup. And it's in the CT scan, her kidney parameters were within the normal limits. There was no obstructive hydrohydronephrosis. There were the renal cortical thickness was also normal from the CT scan. So our plan was initially to give a hemostatic radiotherapy because she had a main complaint was bleeding, excessive bleeding, which was not controlled with the Trenexa. So we planned initially with the hemostatic radiotherapy, and then after that our plan was with a radical intention, that is curative intention, with the radiotherapy and along with the chemotherapy. So as we were planning for radiotherapy, we have taken a planning CT scan that was in December 21. So which revealed in the planning CT scan, there was a non-regional lymph node, which was there was a retrocrural lymph node. So making her a metastatic CS cervix. So we have upstaged the diagnosis to stage 4B. Because she was bleeding, so as planned, the hemostatic radiotherapy was given. And then our radical intention of curative was no further given to her because she was stage 4 upstage. So our treatment intention converted from radical curative to palliative. So during our planning, as we scheduled, we have given one fraction of hemostatic RT. Post 1 week, she presented with a anuria. That was a creatinine of 7.3 milligram per deciliter. And as we, before giving homeostatic CAR-T, we also planned, because during the hemostatic CAR-T, her creatinine was normal. We were thinking of giving a systemic therapy followed by hemostatic CAR-T. But within 1 week of radiotherapy, she presented with anuria with a creatinine of 7.3, which made her unfit for further systemic therapy. So we have counseled regarding the prognosis, options of stunting, percutaneous nephrostomy, dialysis. What are the pros and cons regarding our approaches were explained to the family members and the patients. And as the treatment intention was no more a radical or curative, so we have referred our patient to our palliative care team. So overall, the timeline at initial presentation, she was clinically stage 2B. Post workup, she was 3C2, still with a regional lymph node. During a planning radiotherapy scan, she was upstaged to a stage 4, making her unfit for a curative intention. And she ended up with a renal failure post radiotherapy. And her creatinine levels at the presentation were 0.7, 4 weeks later, which came to be 1.4, 6 weeks later, which came to be a 7.3. And so our concerns for this patient were, she was an young age and she presented with the delay in her symptoms. Like 7 months, she had a initial complaint. She was like visiting nearby doctors, and by the time she came, she had a regional lymph node 3C2, and by the time we worked up, she became a 4B. And the another most important, the topic of today, the altered kidney function within weeks, resulting in renal failure, which made her unfit for a systemic therapy approach. So, and even the options of dialysis and stunting for her with the creatinine of 7.3 were been very beneficial, because there are no randomized control trials, but we have a observational study from our parent institution from Tata Mumbai, which showed a less than, no benefit of any further treatment in patients with obstructive uropathy who had a creatinine of more than 3 milligram per deciliter. So this was the paper I am quoting. So thank you. Now I hand over to my junior colleague. She will deal with how they have dealt palliative care for this patient.
Good afternoon, one and all. Thank you, Dr. Saujanya. And I am Dr. Sumabindu, working as Chief Medical Officer in Palliative Care Department of Homi Bhabha Cancer Hospital, Visakhapatnam. And I'm here to brief how we manage this patient through integrated palliative care. When she entered our palliative care OPD on a wheelchair, she presented with severe back pain and persistent nausea, accompanied with her colleague who was her primary caregiver. Psychosocial history of her revealed that she was divorced and abandoned by her family members who stayed in the same city. Patient was in severe physical and psychosocial distress. And physical aspects she presented with were increasing back pain, heavy bleeding for vagina, multiple episodes of vomiting since a week, persistent nausea, followed up her vagina due to discharge, and increased frequency of urination. Psychosocial aspects include she was an advocate by profession, she was divorced, and so she lived alone and independent. There was a family collusion that she was not supported by her family members, and she also had history of 2 spontaneous miscarriages, and she had no children. She had fair insight into the disease prognosis, and because she is not supported by her family members, she had to depend on her colleague who was primary caregiver. And due to severe fatigue, she was unable to do her activities of daily life, and also she had suicidal thoughts, feeling to self-harm herself because she lived alone and she was feeling that she was dependent on someone. And we managed her with symptoms fairly. Initially, we managed with the start dose of injection paracetamol intravenously and sent home with oral tapentadol 50 mg 3 times a day, antiemetics and paracetamol 3 times a day. Patient reviewed back in 3 days with inadequate pain relief and was switched to fentanyl 12 micrograms patch per hour transdermal in view of deranged renal parameters and vomitings. Because she was vomiting, she is unable to maintain the dose orally. We switched her to patch along with tapentadol 50 milligrams as SOS dose and paracetamol. After 15 days, pain was under control and she had managed without fentanyl patch for a week and tapentadol 50 milligrams OD. Due to poor compliance, we changed her to buprenorphine 10 micrograms per hour transdermal patch with tapentadol as SOS, with which she was comfortable for 2 months. Later, she presented with increasing low back pain and increased BT doses of oral tapentadol 50 mg along with buprenorphine patch, and we continued the same. And she also had fall order for vaginum due to discharge. And based on the evidence of 10-year retrospective study by Dr. Renal, George, we managed with intravenous injection of metrogyn 500 mg 3 times a day for 2 days and 1 course of oral metronidazole 400 mg 3 times a day for 5 days. And later on, she was on oral maintenance dose of metronidazole 200 mg once a day. And for urinary symptoms, at presentation, she had history of increased frequency of urination. And 3 days later, she presented with urinary retention, for which we had done police catheterization and put her on further follow-up as she has deranged blood urea and creatinine levels. Police catheter changed every 2 months because she had pus clogs in her catheter, and we put her on 2 courses of oral nitrofurantoin empirically. Psychosocial interventions. When Mrs. K entered to OPD with severe psychosocial and spiritual distress, on her first OPD visit, we focused mainly on symptom management and listened patiently to her story. She mentioned that she was a divorcee, abandoned by her family members. There was no support from anyone because several siblings staying in the same city and not supported. She was taken care by her colleague, and she was a lawyer by profession, as mentioned earlier. And the colleague is also married. A colleague was also married and he also had a family. Later, when the physical pain reduced, she mentioned about her hobbies, likes, and desires to watch movies, eat her favorite food, and talk to people. She did not want her family to be aware of her disease because she doesn't want any communication with her family. We tried to encourage her in connecting her to her old self, enjoying movies and trying the food she loved once vomiting subsided. Further, she gained some confidence and hope towards being able to manage with her disease. We planned regular phone calls and home visits not to let her feel alone. And on the other hand, caregiver was also counseled regarding ways he could help her, and he could also balance between his family and the colleague and try to reduce the caregiver burden. We asked him to visit the hospital for medication whenever necessary. Gradually, when we visited her home, she welcomed us with a smile and happiness of our presence shown in her face. And she also mentioned that she really liked when we came home. The transition over months was visible. And from her first visit to the later on, she was able to manage with her disease, and she was comfortable with buprenorphine 10 micrograms patch and oral tapentadol 50 milligrams SOS. And psychosocially, she was on the first visit, she had very severe psychosocial distress, and 2 months later it was reduced to moderate, and later on she welcomed us home with a smile on her face. And we followed up with this lady by proxy caregiver visits 6 times in 4 months duration, and communicated in phone calls 10 times. And home visits, we have visited her home 3 times in 3 months duration. And sir, actually, we wanted to know how to intervene this patient because she lived alone and she is unable to manage her activities of daily life because of severe fatigue and ethical decision making with the family members, as she was alone and no family support, and communicating benefits and risk of treatment, and dealing with the relatives about the same. So
Thank you, Suma. Thank you for this presentation. This lady died within 4 months and she died at home, which we also wanted to add. So our points of discussion were mainly about ethical decision making, because we have patients who come to us with creatinine reports and say, now let us go for dialysis. So it's a task communicating, and also the decision making. So we have a tumor board and we make these decisions, but then communicating all this to the family, especially when transitions are rapid, is a problem. So we would like to open this up for discussion. And in this patient, we were able to follow her up, but there are many patients where we are not able to follow up so closely because they live far away. So that's also a challenge. Thank you so much.
Thank you so much, team from Vizag. I think very good discussions points. Really looking forward to getting inputs from you all so that we can all learn from each other. You can either type it in the chat or you can unmute and talk.
Oh, Dr. Sridevi, one of the things that I was interested in with this presentation, whether the pain management was responsible for an improvement in her psychosocial distress, or whether it was knowing that the palliative care team were available and supporting her, albeit often by telephone calls, not necessarily through face-to-face visits. Was there an opinion from the team as to what made the improvement in her psychosocial well-being?
I think a lot of it was symptom management, because we can never forget the first day she came into the OPD. She was in so much distress because of multiple things. Her circumstances, and also the rapid transition of the prognosis. Like at one point we started with curative, and then suddenly over the next 2 weeks she just kind of declined, and suddenly we are telling her, now we are just giving you an RT for hemostasis, and after this it's only pain. So it took us a while but we gave her aggressive symptom control initially. Like we really looked after her the first couple of days, first 2 days injectable, brought down the odor. I think that again was hugely important, because the odor, in fact, we literally identify patients as they step in with the odor in CA cervix. So when we bring down the odor, the amount of self-confidence and the amount of difference it makes to them has to be seen to be believed. So I think with her, aggressive symptom management in the beginning was responsible, but she also, and we had the privilege of meeting her so many times, which doesn't happen with all our patients. So that really helped in the psychosocial distress, to the extent that she died in her sleep at home. So I think both of them were contributory, but this is a very important lesson that we can't address psychosocial distress without good symptom control. I think that's something we need to do all the time.
So I'd like to ask from teams who have experience in working with renal patients, like how do you actually manage the communication? Like what do you tell them about not or choosing conservative management, or because everyone will be asking them, why don't you go for dialysis? And then how long they should go. They will ask all those questions to palliative care team. So probably, yeah, that's where I think we need to learn more in terms of communicating with these patients.
Frank, do you mind answering that question if possible?
Yeah, look, it's this is really tough, isn't it? Because things are happening so incredibly quickly as it did for this lady. And, you know, without an intervention, of course, the person may well die quite quickly there with their significant kidney impairment and very rapidly unfolding kidney impairment. I think, as you said, as the presenter said, this whole process can be, there's only going to be a marginal benefit in really whatever you do. This is not going to be a story where you're going to have a significant improvement in the life expectancy of this person. And part of it also is the psychology of this, because it can be that the sense is, oh, dialysis will save me. Well, unfortunately, the cancer is so aggressive and clearly so aggressive that even with interventions and a dialysis or dialysis, that it may not. So one of the questions that is coming through is, why is this happening? Well, almost certainly there's invasion of malignancy into the ureters and blocking ureters and setting off a back pressure into the kidneys. So, but I would be interested to know other people's perspective there as to how the very question you've asked me, how you then talk to a patient and their family about that. And also access to dialysis and affordability of dialysis may come into it as well. Sri Devi, what are your thoughts there?
No, I was thinking the same line. What if the dialysis was affordable? Should we actually tell them, or will they be convinced? Can we convince them easily for not going for dialysis? Because it is not really affordable for everyone, and they know that it is going to be a continuous process. Then that way, I think we have a little bit benefit in terms of talking them out of going for aggressive management and come to conservative. But what if it is affordable? And I have struggled a lot with people who can afford the dialysis. Then you can't just tell them it is not going to benefit. They are not going to be convinced, because that's what their nephrologist might have told, and that's what everyone around have told them. So,
that's one place I feel cancer palliative care is easier, because it's the non-cancer palliative care which is more difficult. You know, when you have the cancer as a cause, it's easy to address this issue. But like what you said, when in non-cancer and CKD, it's very hard to tell patients about dialysis. That's where we need inputs from how you all do it.
Yes, and that is a tricky story, and I'm very much aware of the significant issues there in terms of access and affordability, and how people can commence dialysis in very difficult situations, and then bit by bit the family is starting to lose, become bankrupt over time, and huge imposts on families and the struggle for that. I do hope that your nephrology colleagues in both situations, cancer and non-cancer, would have an opinion on this, or at least some recommendation for patients about this, rather than simply, whatever you want, we're going to start dialysis. Well, they also hopefully will have some professional response to this.
I think, Frank, certainly that's a very good comment, because even in a high-income setting like here in Australia, I've had experience in this type of situation where the nephrology colleagues will actually suggest, not only to us, but also to the patient, that they are very concerned that dialysis would actually not improve their overall quality of life, and try to explore what it is that the patient actually wants and what's important to them before embarking on dialysis.
Yeah, well, that's encouraging to hear there, Anil, because that certainly the last part of that discussion about what do they want and the quality of life and what's important dovetails perfectly with the language of palliative care. So it starts to sort of become a single sort of conversation, because otherwise it can be a lot of focus on the mechanics of things. But yes, I'd be interested to hear other Indian colleagues there in terms of your approach is this. Dr. Nazir has got, you're muted.
I was wondering what do others, any other team from India, do they see patients with kidney disease, and how do you deal with the conversation?
Hello.
Yes, yes,
Yeah.
please.
Hello, I am Dr. Iqbal from Kachar Cancer Hospital. Thank you very much, Dr. Brennan sir. Brennan sir came to our hospital. We are very much grateful that Brennan sir visited Kachar Cancer Hospital few years back, and he had taught us, basically there was a very intensive class on renal supportive care, and still remember his lesson. And I want to share an experience of mine, while dealing with a CKD patient. Actually, she was the wife of a doctor who was admitted in an ICU, not in a cancer hospital. And I asked called to see the patient. So I paid a courtesy visit to the patient, and then the doctor told me that his wife was not sleeping for a long period of time, and we have given all those pain medication, drugs, but we are not able to sleep. So I went to see the patient, and I asked Madam that, Madam, what is causing your sleep disturbances? So she told me, yes, I'm not able to sleep. Whenever I go to sleep, I feel like sleeping. My feet starts trembling, and also there is itching in lower part of the limbs. So I immediately realized, that what Sir Brennan sir taught, then I prescribe her beautiful drug, gabapentin, and that is very low dose, 100 milligram every alternate night. And to my utter surprise, the next day when I went to her and I asked the question, she herself told that I had the best sleep over the last few months. This drug helped me in sleeping because my itch has gone, and as well as my restless leg syndrome, that with what I diagnosed, So this is a very, very interesting thing, which I think many patients lingers day in and day out in many parts of the country because of the lack of renal supportive care. And I am very much basically blessed to have our Brennan sir today also, and earlier also in our hospital. And as regards the cancer care, we do see a lot of cervical cancer patient here coming mainly in the stage 4 with grade 4 hydronephrosis. We don't advocate, as you all do, we don't advocate PCN. These are very much troublesome for the patient. They hang too back by the side, and also, but they do provide some temporary relief in providing relief of nausea, itching, and other obstructive uropathy symptoms. But they derail the quality of life. They make the patient life hell. Unless in certain circumstances in early stage cancer, where a patient is young, the performance status is very good, then we do intraureteric stenting, and also they do PCN, then internalize the stent if they anticipate that this is going to relieve the obstruction. So and if the patient is planned for radical curative treatment, and of course we do all the symptom management as we have learned from Dr. Brennan. Thank you very much. Thank you.
Thank you, Dr. Iqbal, for sharing your experience. We have one question in the chat. What if there is electrolyte imbalances along with increased creatinine? Then do we need to encourage dialysis?
Dr. Siddhi, can I react also to this?
Yes, sir, please.
This regarding the previous presentation and the comments by this Dr. Iqbal. Say, am I audible?
Yes, sir, very clear.
Yeah, this patient regarding this presentation, in this case, though we don't have cervical cancer in Kashmir, we have just 20-30 cases per year. But if such a case is there, we do perform PCN because the limiting factor for the treatment of the primary disease was rising creatinine, which was basically because of the obstructive neuropathy, because of the disease in the pelvis. So in these cases, if we go for temporary PCN, maintain the outflow, maintain the creatinine will come down, and then we can treat the primary disease. By then the obstruction will go and the creatinine levels will come down only, and that will permit us to treat the primary disease. And that is how we can manage these cases. So it was regarding that thing. I don't know how they will react. I think the PCN is one of the options where there's an obstruction to relieve it, and the levels of creatinine will come down, and then go for the radical treatment in the form of either radiotherapy or systemic chemotherapy. That is what I wanted to say.
Thank you, Dr. Nasir. Frank, would you like to address that question of what if there is an electrolyte imbalance, then should we encourage dialysis?
Yeah, this is a very interesting question. Ideally, it would be a nephrologist answering this question. But look, I guess the main story there, of course, is the rapidly deteriorating renal function and essentially end-stage renal disease that's unfolding here. The electrolyte story, yes, and it's particularly the potassium that is the story. And that may... So I guess we've got a choice there as to what to do. Do we treat this conservatively as in non-dialysis way, which would be potentially using a medicine to try and bring the potassium down, but mainly it's going to be a preparation for this person to be dying soon, sitting with the family, explaining that this is a very, very serious story. We've just heard from Dr. Nazir about the PCN intervention as well. And it may be that's another route to take rather than dialysis. But yes, that it can be in an extremis, that everyone's in a panic, and it looks as though the only way of dealing with this situation is to dialyze the person. If that were to occur, then I think it'd be a question then for the nephrologist as to how long will you continue with this, because inevitably the cancer itself, the anorexia cachexia of the cancer, is going to catch up with this person. So the dialysis is not the only answer. It's going to buy a bit more time, but we also need to be conscious of the cost, and all of those things comes into play. Yeah.
Thank you, Frank. I think Gauri, sorry.
Oh, I just have a question about if you were not to go down the dialysis route and you were to go towards stenting or nephrostomy tubes, then you have to have a discussion, I guess, with the patient about will they be changed or will they be on antibiotics, because I guess they can't stay in for longer than 6 to 8 weeks. And, is that like we're just doing this as that's the last kind of intervention that we'll be doing, and then we'll worry about symptoms from there on? And what if the stents get blocked or the nephrostomies get blocked? I guess that's another conversation that we have to have.
We do have a lot of patients on nephrostomy and on stents and on, but there's the decision. That's why we have a joint clinic, because this lady was staged. She went into stage 4. So there was, whatever we did, her goal was going to be palliative. So that's where I think the conversations, the ethical decision-making, pros and cons, this discussion takes a lot of, it takes a lot of time. It's of immense importance. And so we have to really sit them down and talk to them, because we do have patients on nephrostomy and stented, but they are the ones where the goals are usually curative. But once the goal becomes palliative and you know that the disease has spread, it becomes even more imperative. And sometimes, like what we say, age, we get carried off with age, but then the most aggressive cancers happen in the younger ages. So, though there's that emotion also that comes in. So that's where I think it really helps to have a tumor board and joint clinic discussion so that we have all perspectives.
Thank you, Dr. Vidya. Dr. Gauri has shared a link, Kidney Health Australia. which has great resources. So you can all use that link for reference. I know that there is no clear-cut answer for communication, especially in this particular situation. And I'm glad to see how your team has actually managed from the day when she came with severe pain, and then she started smiling and towards the end. And that's a great work that you and your team has done. Thank you so much for bringing this up for today's discussion. And I think I'm rushing to the next presentation. Yeah, Dr. Nazir?
Yeah. Should I start?
Yes, sir, please.
Good afternoon. Thank you very much, Dr. Shivji and the team of Ecopalium India Trust, who gave me an opportunity to share our day-to-day problems which we are facing with the patients. So next. This was a patient with the diagnosis of cancer of breast. Histopathology was invasive ductal cell carcinoma. It was stage 4 because she had lung metastasis at the time of presentation only. And she was hormone positive with HER2 negative, which subsequently has become negative. Then. Next. Her presenting complaints were diffuse pain all over body. She had more headache, pain in the chest where biopsy was taken from the breast. She had loss of sleep, loss of appetite, and general weakness. Next. So this is the history of present illness. Just 35 years young female. She got diagnosed with breast cancer in June 2020 in the 5th week of her pregnancy. She had undergone cesarean section at 7th week, delivered a live baby. Patient had lung metastasis at the time of presentation. So in view of stage 4, she was put on systemic chemotherapy. During treatment only, she continued to have headache. So for that, MRI brain was done, which revealed metastasis, and that metastasis was treated with palliative radiation therapy. Next. Next. The medication she received, even during pregnancy only, it was decided that she was put on injection ipirubicin as a systemic chemotherapy, which is safe during pregnancy. And then after delivering, she was put on paclitaxel carboplatin 6 cycles, which continued up to January 2022. Since she was hormone positive initially, so she was put on leprolide and tamoxifen as well. Then, but though she continued to have pain, diffuse pain, as I have mentioned, diffuse pain, headache, and loss of sleep, appetite, etc. She was put on step 1 and step 2 analgesics along with adjuvant treatment, but she failed to relieve this pain. Even she was initially treated not at our institution, she was treated at Tata Memorial Hospital and then the other departments, and subsequently she was put on there only on tablet morphine 30 milligrams 6 hourly before being referred to our center, Kale and Palliation at Sikkim. Next. So other conditions, and the main conditions with her was that she was married for 7 years and she had not conceived during this period. So finally she had undergone in vitro fertilization. For which unfortunately, even during pregnancy only, she developed cancer of the breast. Next. So the investigation, besides this, we routinely do the baseline investigation like CBC, hematology, biochemistry, lipid profiles, other things. She had undergone CT scan of the chest, abdomen, pelvis, MRI brain was done, then biopsy taken, and subsequently PET CT was also done. Next. So when she was referred to us with the complaint of mainly pain, headache, and loss of appetite, loss of sleep, restlessness, and other things. And so at palliative care, what we did, we simply admitted her initially, gave her nutritional support because she was not eating well. Though her performance stats was well maintained, but she was not taking an adequate diet. Then she was palliative. She had a pain in the biopsy side of her breast. She was not treated radically with radiation therapy because of the stage 4 disease initially at presentation only. So this breast wound area where she had pain, that was irradiated and palliated with radiation therapy just for relief of pain only. And in the ward only, while she was admitted, she was put on injection morphine 0.1 milligrams per kilogram of body weight, which was around 6 to 7 milligrams was given to her. So which we gave one injection of morphine in ward only. She does show an excellent response. Her pain subsided all over, but it repeated. The pain again came. So she was just free of pain 5-6 hours. And so we continued injection morphine, not the titration way, but 6 hourly. And then adjuvant treatment, symptomatic, was orally given whatever she needed. Next. And then the psychosocial aspects which were with her, she was quite disturbed with her past experiences and has lost all hope of living, because due to self-blaming, she is no longer willing to cooperate in her treatment plan, because she is facing sleepless nights and has stopped talking even due to an anxiety, pain, and other psychological stresses. Next. So main concern, mainly, she was always saying that she wants to live a pain-free life. Next. Now, in summary, she was young, 35 years old, diagnosed with breast cancer, treated with palliative chemotherapy and hormonal therapy. She continued to have progression of disease, which was associated with pain, which was not relieved by the analgesics, even in step 3, that's morphine. Next. So discussion point is, in this case, this is the routine, because this patient, this lady has multiple factors. Briefly, I have mentioned it. And then the issue of pain was main there. Though she was put on 30 milligrams of morphine outside our institution, outside our department, then we continued it, but she did not respond. But she responded to injection morphine. Then while shifting to orals from injectables, she continued to have pain again. So this was the biggest issue with me. That's why I wanted to share it, that how much time we can continue injectable morphines, or how to deal with this while shifting when they respond to injectable and not respond to orals. And then second is this psychosocial aspect, because of the bad history, which I have mentioned, that she had no child, but now she has a live baby, but she is now touching with the pain, struggling with the pain, and so she has a problem now. And then counseling does not help. So what should we do at this stage? These are the discussion pointers. That's what we wanted to share. Thank you.
Thank you, Dr. Nazim, for bringing in very interesting or patient with a lot of learning, probably to your team and for us. I'm so sorry that we are slightly running towards the time to finish. So I would appreciate quick comments or response from the participants or everyone. But how do you go about managing the pain in this patient? Now she's on 60 milligram every 4 hours of injection morphine. So what should be the next step in terms of pain management? Dr. Kale, we can't hear you.
Can you hear me?
Yes, yes.
Morphine gave response, but not oral. This doesn't happen. I don't know how it has happened.
So I think Dr. Kale is trying to tell that a patient who is not responding to oral, responding to injection, is that
this never happened.
Dr. Anil, would you like to take that, like when you change from oral, change the route, how do we manage pain? Like we do that almost every time from oral.
I think that unfortunately there are a number of people, for reasons that may not always be clear, that the transition from injectable morphine to oral morphine does not control their pain. And sometimes I think the initial point might be that there may be an absorption problem, perhaps, or sometimes the mechanism as to why the oral dose is not controlling it, we never come to an adequate explanation. I think, but I do think that it is a problem. So in If there is the option for a transdermal preparation, such as a fentanyl patch, that may be worth considering. Otherwise, then, and previously, one of the sessions that we had looked at the option of methadone, which obviously we're aware that not everyone may be experienced with. And always looking at what non-opioids may be appropriate for this situation. Have we considered all of the other categories of pain medicines?
Thank you, Dr. Nilivan. I was thinking in lines of methadone, and we do see sometimes a good response when we change the route from oral to subcutaneous or intravenous. The exact mechanism is not known, but we do try that when patients not responding to morphine orally, when they come and then we change the route, sometimes they give good response through systemic route. And there is a question on SSIs. Is there any benefit in adding by SSI? I guess you mean SSRIs. I did not, maybe I'm mistaken. Dr. Kinley, can you yeah, so is there any added? I think as the Vizag team is mentioning about reassessment of pain, something that I would like to support too. Probably we may have to revisit, especially when you're dealing with difficult pain. It is always good to go back and see the pain, assessing the pain again. Probably the pain pattern might have changed in between, or you might have missed something during the course of illness. So it's always good to go back and reassess the pain and then start from there. And Tara is mentioning that assessing the total pain and trying to address the complex issues might be of some help. Gauri is suggesting about paracetamol. Unsure, not that this patient was already on high dose morphine, but just a thought that she's thinking whether paracetamol will be of some help. Any other comments from others?
So potentially, yes, an SSRI or any other adjuvant neuropathic analgesic, whether it might be, I suppose in my practice, it might be either one of the gabapentinoids or perhaps amitriptyline or sodium valproate, occasionally duloxetine. I think only though if I felt confident with the character and nature of the pain, as well as the potential likely cause of her pain.
And probably now she's, sorry, Frank, please.
Oh no, sorry, I'll let you speak, sorry.
Sorry. Now, I was just thinking if the pain they are giving every 4th hourly, if she has good pain relief for initial 2 to 3 hours, probably we can think of a continuous infusion than an intermittent dose. But that depends on how much pain relief she has in the initial few hours, or is it no response at all, then probably that may not be an option. But if there is some response and the pain is coming back before the next dose, probably an infusion, continuous infusion might be worth a try. Yes, Frank, please.
Yeah, look, this is such a tragic and difficult case, isn't it? And so I would say, as everyone has been saying, is that you really need to be doing going along 2 paths simultaneously. The first part is addressing the nature and looking carefully at the nature of this pain and being very conscious that this pain may be only partially opioid responsive, though we did see an interesting improvement there with subcut versus oral. So that immediately starts to look at adjuvants and methadone and other agents as well. So being creative in your pursuit of this, and I agree with Anil's list of potential medicines that might be thought about. But the second part, of course, is the psychosocial dimension of what this poor woman is going through, and being conscious of how that interplay can be so strong and powerful, the sense of what she's feeling emotionally. And doing, and I guess one of the great things in palliative care, we can do those two things simultaneously. We can sit with the physical nature of what's going on, but also recognize the emotional dimension of things. And as with that first case, not abandoning her and being kind to her.
Any other comments from anyone else? We just have 1 more minute for session to end.
Sirvedi, just can.
Yes, Dr. Nazar, please.
I just wanted to add one thing. This we had tried many things, and like in this patient, like gabapentin, amitriptyline, pantanyl patches, and other things. But the methadone is not available with us. That is the only thing which we are lacking at present. Rest of all we have not tried. I think that what we may try, and we'll think over other things on which has been already suggested.
Thank you, Dr. Nasir. And I think both teams today, we've seen how the whole psychosocial aspect impact on the total pain. Both of them are very young patients with a lot of psychosocial issues contributing to the total pain. And in the first patient, we have seen how the team, I'm sure Dr. Nazir's team also might have was there along with her journey, or still there with her during the journey. So it shows how important it is to be not just medications may not be helpful, but also the whole team supporting psychosocial, addressing the psychosocial issues are also. And I think first case, we have seen how the symptom management reduced, contributed towards reducing the total pain. And here we are struggling to manage that symptom of pain, which might be contributing to the total pain. Thank you both teams, team from Vizag and your team from Dr. Nazir's team from SKIMS. Thank you so much for bringing in such wonderful points for discussion. I know that there were no clear-cut answers for or conclusions from today's session, but that's how we all learn from each other, by discussing and trying out new things in our practice every day. Thank you so much, Frank and the Hamrahi team, for actively participating as like all the sessions. Frank's presentation will be shared with everyone, because I know that there is a lot of information. We need to go through it again and again and refer it back and forth, so that we also can learn a little bit more on that. Anil, would you like to close the session?
Thank you, Sridevi. Just to say, it's already been put on the chat, and I think we'll all be receiving both the emails as well as the WhatsApp messages. Please do complete the feedback form, because that really helps guide what we do in the future. Thank you. And so the next session is actually scheduled for Tuesday, the 11th of October. And the topic will be pain screening, and we will be in touch in due course about that.
Thank you.
Thank you so much, everyone.
Thank you.